Good afternoon, everybody. My name is Motasem Hamdan, and I am a faculty member of Al-Quds University School of Public Health, and also a vice president of the university. I am very happy to be with you in this session, the session on health economics and health systems, and this is the session before the closing session. And this session we will have in this session three interesting presentations related to healthcare system functions. The first will be about universal coverage in healthcare by Dr. Mohammad Abu-zaineh, and the second will be on assessing economic assessment of healthcare delivery model for cancer patients by Dr. Mohamad Khleif, and the third will be about health workforce regulation and accreditation by Dr. Shahenaz Najjar. So before moving to the first, introducing the first author, I would like kindly to ask you to prepare your questions, to write them on the chat, and also to be ready if you would like also to pose the questions to the presenters orally. So our first author is Dr. Mohammad Abu-zaineh, and Dr. Mohammad Abu-zaineh is an associate professor at Aix-Marseille University in France. And he is the founder and the coordinator of the AHEAD Research Network. And he is also at the same time fellow at the French National Institute of Health and Medical Research at Aix-Marseille University. So let us listen to Dr. Mohammad's presentation first.
Hello everyone. I'm glad to participate in the Lancet Palestinian Health Alliance Conference, the Health of Palestinians, for this year. And my name is Mohammad Abu-zaineh. I'm Associate Professor of Economics at Aix-Marseille University, and the paper I'm going to present to you today is entitled Attaining Universal Health Coverage in Palestine, is Informality and Irreversible Hurdle for Universality. This work is co-authored by Samira Awadi, who is Assistant Professor at Birzeit University. Let me start by this general introduction that aims at setting the scene. As you know, universal health coverage is among the social development goals of 2015-2030. It's the goal number 3.8. This goal has actually two main specific objectives, which are to ensure access to quality and essential healthcare services and to ensure financial risk protection against future uncertainty. As you also know, there was a rising interest in universal health coverage, which is due actually before the SDGs of 2015. And this commitment has been manifested itself by several resolutions and policy statements on the part of policymakers, which all aim at accelerating efforts to attain universal health coverage. Despite this rising interest, there has been little theoretical and empirical work to assess ex ante the feasibility of universal health coverage and the potential impact at micro and macro levels. We know that in developing countries, progress toward universal health coverage is still slow. General figures tell us that more than 50% of the population are still not covered by any health insurance programs in developing countries as a whole, and about 44% of health expenditures still comes from out-of-pocket expenditures by households, while 20% comes from public sources, mainly the governments. Statistics also tell us that about 13 to 15% suffer from catastrophic healthcare expenditures due to this direct expenditures at the point of consumption, and about 3%, are pushed into poverty or below the poverty line due to this direct expenditures. The coverage of health services are still also shallow, low. Generally, about 40 to 60% of services are covered. One of the main policy issue in universal health coverage is the feasibility of including those who work in the informal sectors as well as the vulnerable groups who are usually left behind the efforts to extend the coverage, and this represents actually a serious obstacle toward accelerating the implementation of universal health coverage. In the local context of the occupied Palestinian territory, the context that we study in our research here, the main health insurance is the one operated by the Ministry of Health, which is the governmental health insurance, with a share of covered population of about 60%, and the share of out-of-pocket expenditure is still high despite this relatively high coverage rate of the population, which is about 40 to 46%. The share of government health expenditure from total health expenditure has increased, but remains low, about 33 to 40%. And as regards to the informal sector, the presence of large informal sector, about 60% of the total population, still represents the main obstacle in the local context of the occupied Palestinian territory to accelerate the progress towards universal health coverage. Our objectives here in this research are to assess the feasibility of expanding coverage to informal sector workers and employees on a contributory basis. And we attempt to answer two main questions. What would be the impact of implementing universal health coverage on the government budget? And the second question is, what would be the impact of implementing universal health coverage on social welfare of heterogeneous households, mainly the informal workers? Our data came from different nationally representative surveys, mainly the Households Expenditures and Consumption Survey, the BEX of 2011, the Labor Force Survey of 2015, and the Demographic Surveys of 2010 to 2015. These are surveys that have been conducted by the Palestinian Central Bureau of Statistics. Our macro data comes mainly from the social accounting matrix of 2011, and many of the macro data were also obtained from the several Ministry of Health annual reports that provide us, of course, with detailed statistics about the different aspects of health and health expenditures in the occupied Palestinian territory. We employ a dynamic stochastic general equilibrium model. I'm not getting into the technical details of this, but the main building block of the model consists of 4 agents: the households, business firms, the government, and the foreign sector. We include households which are differentiated based on their employment status, mainly formal workers, informal workers, and employed. We also take into account the variation in the socioeconomic status of the population based on income quantiles, and the health insurance status, distinguishing between formerly versus newly insured households. We assess the feasibility of universal health coverage, basically extending the coverage to the informal sector workers at both macro and micro level. The feasibility at macro level is captured by the government budget indicators, mainly government revenues, expenditures on health and non-health expenditures. As regards the feasibility at the micro level, we attempted to measure the impact on informal sectors workers welfare using a specific indicator which is borrowed from economics. This is called the consumption equivalent variation, which is defined as the amount of additional consumption a household would need to move from the ex-ante level of utility, i.e. prior to the implementation of universal health coverage, to the ex-post level of utility. If this indicator, which is abbreviated to CEV, the consumption equivalent variation, once again, if this indicator is greater than 0, then this indicates that the households would be better off joining or after joining universal health coverage. Or also we can interpret this as an indicator of households' willingness to join and pay for universal health coverage. So it's all about the sign of the consumption equivalent variation, a well-established indicator in microeconomic theory. We assess the implementation of universal health coverage under 4 scenarios. As you see here, we have, first of all, S1, which stands for the universal health coverage implementation. In this scenario, we assume full coverage of the population, but a low coverage of healthcare costs, about 57%, sorry. We assume that only formal workers contribute to health insurance with a rate of contribution that is equal to 5%. The contributions of unemployed and the informal workers are fully subsidized by the government. Under the second scenario, we assume a more generous universal health coverage with a coverage rate of healthcare costs that is increased up to 70% of total health care costs. And under the third scenario, we introduce an increase in consumption taxation by 2% point to allow to finance the health insurance. And under S4, the last scenario, we include the informal workers under a scheme that allows them to be covered up to 60% and paying 40% of their incomes as contributions to health insurance. The results are presented in these 2 tables. The first table, we assess the impact of universal health coverage at the macro level. Figures are reported in percentage change. As you see here, we are interested in assessing particularly the impact of government health expenditures. We can see that under S1, there is a significant increase in government health expenditure, which is expected due to the increase in the coverage of the population. We can also see that the impact is negative on the government non-health expenditure, which is also expected given the limited fiscal space of the government. So this indicates that there will be some crowding out effect on the expenditures of other sectors. A more generous universal health coverage would, of course, imply a higher crowding out effect and a higher increase in government health expenditure, which is also expected. We can, of course, allow for additional financing for healthcare for universal health coverage through increasing consumption taxation as under S3. This, of course, allow the government to increase even more its health expenditure. But this increase will gets smaller in 2030, and we have a lower actually crowding out effect on the government expenditures on other sectors if we introduce consumption tax to finance universal health coverage. Allowing informal sector workers to join universal health coverage would also imply a crowding out effect, but this crowding out effect will vanish over time. So we have up to 3.19% of crowding out effect in 2030. We are also interested in assessing the impact of universal health coverage on informal workers' welfare using the CEV indicator that I have explained before. So similarly, here you have the 4 scenarios, and we have the informal workers who are newly insured or newly covered by the universal health coverage. Interestingly, we can see that for this group of population, the impact on their welfare is always positive, indicating that they are willing to join and to pay for universal health coverage, to join the universal health coverage and pay for it. All figures are positive here, almost, let me say. So we can see that the welfare impact is particularly higher for the poorest groups of the population, indicating that the welfare impact on this group of the population would be higher or will be enhanced by introducing universal health coverage. Let me conclude by highlighting some interesting results out of this research. First of all, we can see that results from the first scenario, the implementation of universal health coverage, show that the current health insurance plans yield actually welfare gains. We have a positive consumption equivalent variation, our indicator of welfare. And the impact is particularly salient for the newly insured groups. The simultaneous expansion of both the breadth and width of coverage, i.e. the coverage rate of the population and the coverage rate of healthcare costs, would enhance, of course, the welfare of all types of households, regardless of their socioeconomic status and their health status. Time is over, but let me finish by highlighting also the fact that taxation and insurance contributions would generate additional revenues to serve the universal health coverage for particularly the informal sector employees. Thank you again for allowing me to share my work with you, and thank you for your attention. Goodbye.
Thank you, Dr. Mohammed. Really interesting presentation. I look forward for questions of the audience regarding your presentation. And let's move to the second presenter, Mohamad Khleif. Mohamad Khleif is an assistant professor at the Faculty of Nursing and Midwifery, Hebrew University. Mohamad Khleif is also chair of ALSadeel Society for Palliative Care for Cancer and Chronic Diseases in Bethlehem. And he has a PhD in Health Economics and Management. So please, Dr. Mohammed, let's listen to the presentation of Dr. Mohamad Khleif.
Assalamu alaikum wa rahmatullah. Hello, everybody. I am Mohamad Khleif, an assistant professor at Hebrew University and the chairperson of ALSadeel Society for Palliative Care. I'm going to talk about my research about economic evaluation of palliative care in Palestine. The study aimed to assess the economic and clinical impacts of a hospital-based palliative care consultative model for inpatients with cancer in Palestine. The study was a one-year follow-up study that followed adult cancer patients, two groups, one with palliative care consultations and the other without palliative care consultations. No significant differences in the demographic data has been revealed between these two groups initially. The sample was taken from Beit Jala Governmental Hospital, the main cancer treatment center in the West Bank, and consisted of 49 palliative care cases and 146 standard care controls, with over 1,000 follow-up observations on admissions, discharges, and on a monthly basis post-discharge, which revealed actually a pretty good statistical power for the analysis for this sample. The economic evaluation study measured several measures. Quality of life scores has been measured using the European Organization for Research and Treatment of Cancer tool, which is a validated international tool to measure the quality of life specifically for cancer patients. Then, based on those scores, the utility scores has been calculated to reveal the quality adjusted life years. Cost has been also calculated to do the cost utility analysis to compare the cost with each QALY. First, the results showed on average better quality of life for the palliative care cases compared to the standard care controls. Most importantly, we can see here in this graph the trend of better quality of life all the time in the palliative care group compared to the standard care group, with a statistically significant better quality of life on the palliative care group after the second month of follow-up. A linear mixed effect analysis model has been done to reveal what actually makes quality of life better, and it revealed a reliable effect actually of palliative care, namely the stage of the cancer and the symptoms load for cancer patients, whereas expected predictors of quality of life, advanced stage and more symptoms cause lower quality of life. But more crucial to our study is the result that follow-up months for palliative care cases were better quality of life. Patients in the palliative care group has significantly better quality of life after the second month of follow-up for them compared to the standard care group. Based on those scores of quality of life, we used a method developed by Rowan and her colleagues to measure the quality adjusted life years from the scores of the quality of life measure, and it revealed a statistically and highly statistically significant difference between the two groups in the quality adjusted life years for the follow-up period of the patients. Regarding the cost, we calculated the cost from the healthcare system perspective, which is called an economic evaluation C1. And analysis revealed no statistically significant difference between the two groups regarding the cost. The costs were almost similar for both groups. But the main cost drivers, those pushed the cost up, which were actually higher in the standard care group of patients, were the cost of chemotherapy medication and the cost of hospital stay, cost of the duration of hospital stay in the hospital. Those were the main two drivers that pushed the cost up for both groups actually, but more for the standard care group. Starting with the base case analysis and the economic evaluation, we measured the average cost effectiveness ratio, which compares the cost with the utility for both groups, how much cost per quality adjusted life year, and it showed that actually the palliative care group were in better position regarding both the effectiveness on the x-axis, had better utility or better quality adjusted life years compared to the standard care group. Also, they had better position on the y-axis, which is the cost, lower cost compared to the standard care group. This is good, but for economic evaluation is not enough. We need to do more, which is the incremental analysis, incremental cost effectiveness analysis, which compares the incremental effect with the incremental cost between the two groups. And this incremental cost effectiveness plane has 4 quadrants. If the new strategy, which we are studying, palliative care consultative model here, falls in this quadrant, this means this is a dominating cost-effective technology. And this is what happens actually in our study. So you see this blue line falls in this quadrant actually with a negative ISR value. That means it's a dominating strategy. That is, it improves the effectiveness, the quality of life in our case, and it decreases the cost. But further analysis is needed actually because this analysis is based on the average of all the values. So we needed to do a further analysis called the sensitivity analysis for this result to make sure if we put several values, if we varied the values that's used in the analysis, do we still have the same result for this cost effectiveness? And just to explain about this line, this is the threshold line for cost effectiveness. So suppose if the analysis revealed that the result came in this quadrant, if it's still under the threshold line, which has been calculated to be 21,000 shekels per quali for Palestine, that means the new technology costs more, but still cost effective, as it is deserve the money that is paid for the effectiveness that it is reveals. So we did the sensitivity analysis using the tornado diagram of the ISAR. We revealed the most significant variables that affect the analysis, namely the cost of the chemotherapy and the cost of the hospital stay. Using the 95% confidence interval, upper and lower limits for both costs of chemotherapy and hospital stay, length of stay, as well as the limits, upper and lower limits for the utility, the QALYs. One-way sensitivity analysis and two-way sensitivity analysis using multiple scenarios revealed all the time that the new technology, palliative care consultations, in our case, were either dominating or cost effective in all the scenarios. This is a robust result. It proves that the analysis revealed that the use of quality of life, that the use of palliative care consultative model improves the quality of life. So we can conclude that the palliative care consultative model for cancer patients, hospitalized cancer patients in Palestine, is a cost-effective strategy to adopt by the healthcare system. It improves the quality of life for sure, and most of the time it decreases also the cost. This is a robust enough strategy to adopt. It's a wise use of public money in the healthcare sector in Palestine, and special attention is needed actually for resources use regarding the use of chemotherapy, expensive chemotherapy medication in advanced end-of-life stages for cancer patients. Furthermore, palliative care services need to be consistent according to the results that we found in our study. We need a consistent, long-term, continuous palliative care service by a dedicated palliative care team for this model to be successful. And finally, further research is for sure required, a longer follow-up time, and an experimental or quasi-experimental research would reveal further evidence and stronger evidence. Thank you for your listening, and I'm ready to answer any questions after the session.
Thank you, Mohammed. Really also very interesting presentation. Let's move to the third presenter, Dr. Shahenaz Najjar from the American University of Palestine. She is an assistant professor of health sciences, and at the same time, she is assistant dean for academic and student affairs at the university. Dr. Najjar has a PhD in biomedical sciences, and I know Dr. Najjar has a very intensive expertise in patient safety and equality research type. So we are going to listen to Dr. Najjar, and I think she is also working together with Dr. Mohamad Khleif for their presentation on assessing the current situation of human resources for health situation, accreditation, regulation in the Palestinian care system. So Dr. Najjar, please.
Hello, everybody. My name is Shahenaz Najjar. I'm an assistant professor at the Health Sciences Department in the American University. In the coming few minutes, I'm going to present our study on behalf of the wonderful team, Dr. Mohamad Khleif, Mr. Hassan Abu-Abeid, Ms. Aisha Al-Basyouni, and Ms. Sally Mohsen. Our study is on assessment of the health workforce accreditation and regulation in Palestine, a call for immediate policy action. So in the coming few minutes, I'm going to present introduction on our studies, study objective. We'll talk about the methods used and data analysis, main findings and lessons learned from this study. Health workforce accreditation regulation is a key pillar of health system governance, including measures designed to ensure better quality and performance of health professionals. Health workforce accreditation regulates and assesses individual, staff, institutional, and organization based on specific standardization framework. Recently, rapid growth was seen in the health workforce accreditation regulation. Various efforts were implemented mainly by WHO to advance and strengthen practice and activity of accreditation and regulation. The rapid growth was seen in education, licensing, recruitment, practice and performance, which is essential for better preventive, promotive, curative healthcare. In the Eastern Mediterranean region and Palestine specifically, health workforce accreditation regulation is still lagging and needs serious action to strengthen at both national and institutional level. In fact, health workforce accreditation regulation is rarely investigated in Palestine. Our study aims to assess the current status of accreditation regulation, to identify the challenges, and to propose useful policy and technical actions for the effectiveness of health workforce accreditation and regulation. To meet our objectives, participants were selected using purposive sampling techniques. They were key informants as experts, academics, seniors, policymakers from three sectors: governmental, academia, universities, and non-governmental organizations from West Bank and Gaza Strip. The main criteria for our participants were they consent to participate in the study, they have experience for more than 5 years. After getting the technical approval from the ethical approval from Helsinki, invitation were sent to the selected key informants through email. Each participant received all relevant information regarding the study and given the choice to participate in our study. Their acceptance was recorded and documented by signing the informed consent. 22 semi-structured face-to-face interviews were conducted, 11 from West Bank and the same from Gaza. The interview duration was about 45 minutes to 90 minutes. Interviews were done between beginning of October and to mid of November. For data analysis, thematic analysis technique was used to analyze interview data and to identifying and interpretation the pattern, the meaning across the collected data. Data analysis was done using Max CUDA 12 and manually by 2 researchers who analyzed the data separately to strengthen the analysis process and to maintain a strong study result. So the total number of participants was 22 from leadership and technical level, 6 females, 13 were from government, 6 academia, 3 directors from NGOs. The majority have master's and PhD degrees, and they gained experience for more than 15 years with age range between 33 to 64 years old. In the following slides, we will present our results in 4 main domains: conceptual, governance, policy and monitoring, technical practice and resources, factors and challenges of health workforce accreditation and regulation. The study reported lack of health workforce accreditation regulation understanding. Nearly 50% sufficiently defined the term of health workforce accreditation regulation. The current status of health workforce accreditation regulation is lacking. They perceive as scattered and poorly unregulated and unorganized, lack of qualified staff, standards on accreditation and regulation, outdated laws and policies. Regarding governance, policy and monitoring, health workforce accreditation regulation mechanism are inadequately and insufficiently implemented and requires substantial updates and monitoring. The perceptions on the existence of governance system were controversial and no specific body defined. They described the current system as disintegrated, improperly applied, not inclusive, and required essential reform. However, multiple governing bodies were mentioned. Their rules were described as weak, uncoordinated, and independent. National health workforce accreditation regulation policy exists in the national health strategy, but insufficiently implemented and requires substantial updates. Follow-up monitoring, oversight, the operational plan or standardization framework are lacking due to institutional, political, technical, and logistical reasons. When participants asked about, when we asked participants about health workforce accreditation regulation practice and resources, they reported that it is performed with no systematic structured communication and coordination, no follow-up or examination at a low level of quality. Health workforce resources and capacity facing severe deficits except the availability of qualified personnel. Then when we ask them about the common challenges and factors that affects the health workforce accreditation and regulation, the most common challenges were the political challenges, the occupation, political division. The participants from Gaza were more likely to identify political instability among challenges. Participants from West Bank focused more on governance and system challenges and funding shortage, technical shortages, and monitoring and oversight problems. When we asked the participants about their recommendation to address the previously mentioned challenges, they shared the recommendation on 3 levels: national, institutional, and individual level. For the national level, around 2/3 of the study participants recommended developing or updating the national strategy and implementing a plan of health workforce accreditation regulation, including policies, manuals, guidance, Some participants highlighted that the strategy development should engage the Ministry of Health, professional unions, and universities. 1/3 of the study participants recommended developing a mechanism for follow-up, monitoring, evaluation, and data management. And almost a quarter of the participants recommended strengthening sector-wide accountability and unified and transparency policy and measures. They highlighted the importance of establishment of an independent entity that should be concerned with the governance of health workforce accreditation regulation. On the institutional level, around 1/3 of the study participants recommended developing mechanism to make health workforce accreditation and regulation policy more efficient, developing guidelines, better coordination, better accreditation, and repracticing procedures. A quarter of the participants recommended strengthening the role and capacity of professional unions and syndicates. Some expressed the importance of developing an efficient system to track the performance indicators. Others highlighted the need for a new system to monitor, track accreditation, education, certification. The link between continuing medical education and certification was recommended by a few participants. On individual level, the majority of the study participants recommended promoting self-development, continuing medical education. Few recommended implementing this through workshops, conferences, seminars, training courses. Some participant mentions the awareness on accreditation and regulation. A few recommended the stronger engagement with the professional unions. To sum up, our study emphasizes the importance of health workforce accreditation regulation and its proper application as a key pillar of the health system governance. There is an emphasis on the importance of health workforce accreditation regulation for attaining better healthcare and achieving universal coverage. Health workforce accreditation regulation in Palestine is lagging and has a major gaps in understanding structural, legal, and technical aspects. All relevant stakeholders, ministries, syndicates, and academic institutions should work together through an integrated national accreditation and regulation body. This body should be driven by a common vision, well-established guidelines and frameworks, and policy for better awareness, best practice, and effective mechanism. Thank you. Thank you all for listening.
Thank you very much, Shahenaz. Now I would like to return to the audience and for questions.
Good evening. Can I have a question, please, for Dr. Shahenaz?
Yes, please.
Thank you, Dr. Shahenaz, for your very, very interesting, really topic you put for today. But I always saying that whenever you want to succeed, you should start from the roots, and you started really when you make a qualitative research. My question that do you think that your qualitative results can be put into a quantitative, because you have raised many very important issues related to qualitative. You raised issues maybe you will not find in other places. You went into deeply the persons you make a research with. Maybe you take these themes and domains and put into a quantitative research, because the qualitative is a very good start. But if you want to impose the change, we want to make or generalize the results, I think we need also a quantitative research. How do you think about that?
Yeah. Thank you, Maisa, for your research. So your question. your important question. I think, as you know, we have qualitative and quantitative study designs, two important approach that the two ways of doing research, or two methods that can complement each other's. Starting with the qualitative research, as we have done in this study, that was the start of to know exactly what is the situation, what are the factors and challenges that affect the health workforce accreditation and regulation. We got very informative findings from the interviews, especially that it was with the key persons in the sector, in the academia and the Ministry of Health, and with NGOs. All of our findings gave us very important indication about the situation in general. We can, for sure, we had 22 interviews with as a participants in this study. We are working, in fact, we are in the final stage of writing 2 manuscripts from these results, and these results can be representative in a percentage and number. We can for sure go to the next step by doing also quantitative research to build on our results that we got from this study. So I think, yes, we can do for sure additional quantitative analysis based on this results.
Okay, thank you, Dr. Shahenaz. Any other questions? I don't see hands raised here for questions. I'm looking to the chat if, okay. Okay, I can see questions in the chat section. Meanwhile, I would like to, maybe I ask a question to Dr. Mohammad Abu-zaineh. It was interesting to listen to your presentation, Dr. Mohammed. And I have observation. We have been, talking about universal coverage in Palestine for many years, almost maybe more than 10 years. But I would like to ask you, frankly, how do you evaluate the performance of the government and the Ministry of Health in achieving this universal coverage? And where do you see the real challenges for achieving the universal coverage in Palestine?
Okay, thank you for this, for raising this point. Actually, this is not a study about the performance of the Ministry of Health, and it's difficult for me to give any evaluation of its performance. However, based on the data that we have, we can say that our progress towards universal health coverage is very slow, and this slow progress is due to a number of obstacles that you may know very well because they are related to the Palestinian context. And basically, the main challenge that we have found in this study and in other previous similar studies is related to the finance. So I can always refer to the financial issues as the main obstacles in the Palestinian context, given the budget constraint. You know that to expand universal health coverage, we need additional resources. And part of our budget is always or often held by the Israelis. The Palestinian government's budget is limited, and this, of course, does not justify completely the slow progress. We can still do better than what we are doing now by reallocating resources from the, for example, the security sector to other social welfare related sectors such as health and education. This is still a main point in the Palestinian context, actually. It is about the reallocation of resources rather than only keeping on saying that we don't have enough resources to expand towards universal health coverage. We can still do better. Of course, I can't evaluate the whole overall performance of the Ministry of Health, as there are many other issues that I'm not aware of, but the financial issue is the main obstacle to universal health coverage. Of course, there are other important issues that we have to take into account, and our study attempted to address, such as expanding universal health coverage on a contributory basis. And this is really needs to be explored further in the Palestinian context to answer the question of whether can we expand the current coverage based on contributory basis, given, of course, the informality, the large informal sector. By this, I mean the unemployment, the poverty, which is still high. All of these issues needs to be addressed carefully. And of course, we don't have a menu of policies in the current context. We don't have too many options, as you know, Doctor. We have very few options. We have to consider our choice very carefully. And of course, we need to consider the optimal combination of financing that we need to ensure to reach universal health coverage, hopefully by 2030, not 2300. Thank you.
Thank you, Mohammed. Thank you very much. Any questions? Dr. Abdul Latif, please.
أهلا وسهلا. I actually enjoyed the presentation of Dr. Mohamad Khleif very much, in addition to all other presentations. And I have a general question for Dr. Khleif, since he has been working on palliative care before anybody else in Palestine, as far as I know. My question is, what are the main research priorities in palliative care in Palestine, in your opinion, and why? Thank you.
Thank you, Dr. Abdul Latif, and thank you for Lancet, thank you for BIRZIT, and for the Institute of Community and Public Health for this opportunity. As you said, palliative care is in Palestine, as many other countries around us in the region, is starting. It's a new area of specialty that is actually needed, and there's a lot of literature that proves that. And the part that we are participating in our research is a small part to add to this literature for the importance of, and I'm adding to what Dr. Mohammad Abu-zaineh was just saying now about the financial burden. It's either universal health coverage, or it's a specific topic like palliative care or maybe other important topics. The financial burden is always, for us in Palestine, is always a big concern, actually, because we have limited resources, maybe more than other countries. So I believe financial issues, cost effectiveness or cost utility analysis, or economic evaluation researches similar to what we conducted, not only for palliative care, but also for other services or medicines, is one of the priority researches in Palestine, as far as I believe. For palliative care specifically, we need to consider the education of palliative care. Now, recently, we have in new programs developing in Palestine and Palestinian universities regarding higher education in cancer and palliative care. So we need maybe to explore the effect or the impact of these newly added programs, higher diplomas and master degrees in cancer and palliative care, and the effect on the ground, and to show actually or to prove what is already maybe proved in other places, that such service, which is palliative care for cancer patients especially, and for other diseases like cardiovascular or renal diseases, is really an important addition to the healthcare system, and really it needs to be integrated. So any researches within this scope, I believe it's an important area of topic. And thank you again for your question.
Thank you, Mohammed. Any other questions? So I think we have still 5 minutes. I would like to return to Shahenaz to ask something general. Shahenaz, you talked about, the situation of regulation accreditation. On one hand, we see that the government feels the highest responsibility for, the weaknesses in this system. From policy point of view, if we look, because the government, partly they produce human resources for health, where we have, now we have governmental institutions providing this kind of education. In addition, to universities. On the other side, the government also employs the highest share or the biggest share of the professionals in the governmental sector. But when it comes to regulation accreditation, it is still mainly in the hand of the government. Do you see this as a healthy situation, or what we should be doing? I think partially you have eliminated that, but if you can expand on that. Given the situation now is we moved from, more supply of the need of health workforce, more supply of physicians, nurses and other professionals, to now to surplus. And when we came to a situation now, we started to have an unemployment ratio even among those kind of, professionals. Can you elaborate a little bit on this issue?
Yes. Yes, thank you for this question. Very important. I think, internationally we have, we can find in the literature 2 ways of regulating that. The Ministry of Health in some places, they totally regulated and have control on the workforce accreditation and regulation. And in the other part, we find that the Ministry of Health, they have support from councils or other body that work under, that take the control and regulate that work. So the 2 modules are available. In our situation in Palestine, and I think personally that having a body that can help on, or that can support the Ministry of Health of regulating all activities regarding the health workforce regulation and accreditation can be a good idea, a great idea to improve the situation. As you know, we need a lot of efforts to improve the current situation for the health workforce. The accreditation, the re-accreditation for the human resources in the health sector, the continuous education as well, that can also be done within this body, and the regulation on that can be done there. I think the Institute of Public Health, WHO, they already started working on the national database of, for health workforce that also can support all of these activities. So from my point of view, I think that having a body to regulate this activities will be a good idea to help that or to support the Ministry of Health on this activity.
Thank you, Shahenaz. I think Abdul Latif, you have another question?
Yes, I am still raising my hand. Thank you.
Yes,
Motasem.
yes, please. You
I
can
have
use
a
the
question
time. Yes.
for Mohammed. It's an interesting question for me. I hope for others also. It's how would you compare Palestine to its neighboring countries in terms of out-of-pocket catastrophic health spending? It's a general question for Mohammed.
I think Mohammad Abu-zaineh.
Mohammad Abu-zaineh, yes.
Yes. Mohammed, can you hear us? Mohammed, we can't hear you. I think your mic
Can you hear me
is
now?
muted. Yes, now. Yeah.
Can you hear me now?
Yes,
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 Mohammed.
please.
So the question was about the catastrophic health expenditure, if I got it well, and comparison with neighboring country. I actually am not aware of recent figures. The figures that we have are those obtained from the health expenditure statistics from the World Health Organization. It is a platform, a dashboard statistics that are available online, and the figures indicate that we do still have high out-of-pocket expenditure, and it's comparable to our neighboring countries. We don't fare better than them. They don't fare better than us, according to these mash-up indices. Actually, these are some mash-up indices that account for out-of-pocket expenditures and also adjust for access to healthcare services. To my knowledge, we have comparable figures to the region.
Okay, thank you, Mohammed. Any further questions before we close the session? Okay, thank you. I first thanking our presenter in this session, a very interesting session, and the audience of the session also. And I finally would like to thank again the organizers of the conference and for inviting me to be a moderator. Yes, I would like to introduce the moderator of the next session, Dr. Mamdouh Akir. Mamdouh Akir is the Aix-Marseille University Board of Trustees member. So please continue following the last and the closing session, and also there will be also the announcement of the best winners, of the poster winners in that session.